Hope everyone is back there. We are now going to start with non-small cell lung cancer. And in this course, we will only do non-small cell lung cancer. There is also a small cell lung cancer, but non-small cell lung cancer is the most common type of lung cancer. Actually, in 80% of the cases of lung cancers, the patients have non-small cell lung cancer, and there are many subtypes of non-small cell lung cancer. So today, we will do half of this lecture, and in the next session, we will do the treatment. So in this lecture, we will go only up to the staging of non-small cell lung cancer, okay? Right. So lung cancer is the leading cause of cancer death worldwide, with approximately 90% of cases being attributable to smoking. Now, lung cancer worldwide is the most common cancer in men. The second most common cancer worldwide is prostate cancer. But in the USA, the most common cancer in men is prostate cancer. And the second most common cancer in men is lung cancer. In women worldwide, it is I think it is lung cancer is the third most common cancer. The second most common cancer in women is colorectal cancer. And the most common cancer, obviously, is breast cancer in women. Now, the thing about lung cancer is that it is the most deadly cancer. The mortality rate in lung cancer is the highest among all cancers, okay? And as you have seen that 90% of the cases are attributable to smoking. Now, lung cancer is often divided into two types, as I just mentioned, small cell lung cancer and non-small cell lung cancer, which accounts for 85% of all lung cancers. Small cell lung cancer is characterized by its central location in the lungs. Central location means close to the airways, rapid tumor growth, early metastasis, and association with numerous paraneoplastic syndromes. Paraneoplastic syndromes means the cancer is synthesizing and releasing certain hormones like ACTH, adrenocorticotropic hormone, all right? And that's all about small cell lung cancer. Now we go on to non-small cell lung cancer. Histologic subtypes of non-small cell lung cancer include adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Most lung cancers are diagnosed at an advanced stage, conferring a poor prognosis. Well, that's the problem with lung cancer. It is not diagnosed early. When the patient gets signs and symptoms, some problems, I'll show you what the signs and symptoms are. Cough is the most common symptom. There could be hemoptysis. There could be pleural effusion, difficulty in breathing, many presentations, okay? But by the time the patient comes to the doctor, it is in an advanced stage. Now, here is a distribution you see. This is adenocarcinoma. What I've shown you over here is this is the most common form of lung cancer or non-small cell lung cancer. More than 50% of the cases of all the cancers and also of the non-small cell lung cancer are adenocarcinomas. And most of the people who get this cancer are smokers. Now, small cell lung cancer also, a very small fraction of patients are non-smokers. Okay, most of these are smokers. Squamous cell carcinoma, which is a type of non-small cell lung cancer, again, very small percentage are non-smokers. Here again, non-smokers, and large cell carcinoma, very small percentage is non-smokers. So The conclusion or the bottom line is that it's a disease of smokers. 90% of people who get lung cancers have been smokers. But if you take into account all the smokers, if you take all the smokers, only 20% of smokers, they get lung cancers. So it's a bit complicated. Right, pathophysiology. Following factors are thought to contribute to the risk of developing lung cancer. Again, the risk factor, it's smoking. Okay, because there are so many carcinogens, cancer-producing substances in the smoke, in a cigarette smoke. And nitrosamines, these hydrocarbons, polyaromatic, I'll just show you in a minute. So exposure to environmental occupation carcinogens, 90% due to smoking, a few due to radon, outdoor pollution, 10% due to occupational carcinogens. And among the occupational carcinogens, the most common is asbestos. Okay. Then the other thing is individuals' susceptibility. There are certain genes which are more important in lung cancer, and I'll show you those genes. Okay. Now, tobacco smoke contains at least 40 known potent carcinogens. Okay. Some books write it has got more than 40 carcinogens. And it has got a lot of chemicals in it, okay, chemical compounds in it. So the carcinogens, the most important carcinogens are polyaromatic hydrocarbons and nitrosamines. Nitrosamines are there in smoked food as well. It's in smoke. So smoked meat, that could lead to gastric cancer as well. These compounds cause DNA damage and gene mutations. Maybe they produce free radicals or whatever. Now, there are certain diseases that can increase the risk of lung cancer. And among those diseases are COPD, chronic obstructive pulmonary disease, and tuberculosis, and pulmonary fibrosis. They all have been shown to be associated with increased risk of lung cancer. Genetic susceptibility. Advanced molecular techniques have identified amplification of oncogenes and inactivation of tumor suppressor genes in non-small cell lung cancer. Now, what do we mean by gene amplification? Gene amplification means that there are many copies of the gene. So let us suppose that I have one copy of a certain oncogene, whatever gene it is, maybe it is c-MYC, that's an oncogene. Amplification means maybe I'll get 20 to 30 copies of that gene. How do I get that? That's some problem with DNA. Okay, it's a type of DNA alteration or DNA change. So the most important abnormalities detected are mutations involving RAS family of oncogenes. In 30% of cases of adenocarcinomas, there is a RAS mutation. Okay, RAS are oncogenes are those genes which cause cancer. If they are expressed, they will cause multiplication and division or proliferation of cells, right? So oncogenes, before they become mutated, they are known as proto-oncogenes. So when proto-oncogenes develop a mutation and they start increasing the rate of cell growth, they are known as oncogenes, okay? Other molecular abnormalities found in non-small cell lung cancer include oncogene mutations, c-MYC, CRAF, okay? Tumor suppressor gene mutations, retinoblastoma and P53 I've mentioned in breast cancer as well. Now, oncogenes, they gain function, in cancers, they are overactive. Tumor suppressor genes are good genes. They suppress the tumor. So tumor suppressor genes, they are inactivated in cancers, whereas oncogenes, they become overactive in cancers. All right. Another thing you need to remember about oncogenes and tumor suppressor genes is that we get 2 copies of each gene because we get 1 copy from the mom and we get 1 copy from the dad. So in oncogenes, we need a mutation of only one copy of the gene. Whereas in tumor suppressor genes, we need a mutation in both the copies or inactivation of both the copies of tumor suppressor genes, all right? By the time the tumor manifests clinically, extensive mutations have already occurred that result in pronounced intra-tumor heterogeneity. Now, this is another very important concept that I've explained in my pathophysiology lecture. Heterogeneity means different cells in the cancers have got different growth potential. Some cells, because once the mutations start, it is the mutations, they go on happening, they go on increasing. Some cancer cells will get one set of mutations. Other cancer cells will get another set of mutations. So some cells will have a greater survival advantage. That is how we call it. The cells that are multiplying very rapidly, we say that they have got a survival advantage. So some mutations will confer a survival advantage. Most of the mutations are deleterious mutations. They will cause the cancer cells to die. But it is those cancer cells that acquire mutations that are dangerous, right? That cause the cell to divide faster. Those are dangerous cancer cells. So within the cancer, there are many different types of cancer cells. This explains why these cases fail to respond to therapy. Now, this slide is for your reference. It gives you the characteristics of adenocarcinoma, squamous cell carcinoma, and large cell carcinoma, okay? It's difficult to memorize the tables, so you can keep it for your reference when you go to your clinics. And in this slide, this part is for reference, but this part which I have written included, this will be included in the examination. So smoking is the cause of cancer in about 78% of men and 90% of women with lung cancers, okay? Two recent studies have reported rising non-small cell lung cancer in persons who have never smoked. Now, that is a problem, 90% of women means that 10% of women who don't smoke, they also get lung cancers. And 22% of men who don't smoke, they also get lung cancers, all right? So the the persons who never smoked, for some reason, there has been a slight increase in lung cancers. In the United States, rates increased from 8.9% in 1990 to 19.5%. That's a significant increase in, say, 23 years. In the United Kingdom, a study reported an increase from 13% to 28% during a 6-year period. Now, why is this happening? We don't know. I didn't find any reason for that in the literature. Epidemiology in the United States, lung cancer is the second most common cancer after prostate cancer in men and after breast cancer in women. Okay, so in the United States, it's a little bit different from the rest of the world. In the rest of the world, lung cancer in men is the most common cancer. It is the most common cause of cancer death. So the bad thing about lung cancer is that the mortality rate is the highest in lung cancer patients. Global lung cancer trends have followed the trends in smoking. So wherever there is more smoking, there is more lung cancer. Lung cancer incidence has been declining in several countries following decreasing rate of smoking, and the examples are US, UK, and Canada. And age and sex distribution, lung cancer occurs predominantly in persons aged 50 to 70 years, and it's pretty low in people below 39 years of age. So lung cancer, like all other cancers, is a disease of old age. Overall, lung cancer is more common in men than in women. And incidence in race, again, unfortunately, a lung cancer occurrence is approximately 45% higher in African-American men or African-American population, increasing women as well. Prognosis, as I said, mortality rate is the highest. Lung cancer is highly lethal. The 5-year overall survival rate is about 12.3%. This is very low, okay? The 5-year relative survival depends on how advanced the disease is at the time of diagnosis. Now, this is an important thing to understand, okay? And you have to remember this thing as well. Localized disease, the 5-year survival rate is 59%. Again, it is not very good, although it is close to 60%. But if you compare it with other cancers, you know, localized disease, it has not spread. It is very, 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 very small. The tumor size is very, very small, okay? And maybe it has not gone to the lymph nodes. Regional disease means it has spread to the lymph nodes or to surrounding structures. It has not gone to distant structures. So 5-year survival rate is 31%. And distant metastasis, the 5-year survival rate is just about less than 6%, all right? So very aggressive cancer. Now, there is one more thing, you know. The thing, it also depends upon that what was the stage of the cancer at the time of diagnosis. That I'll show you in the next slide, okay? So prognostic factors for lung cancers in non-small cell lung cancer, it is the stage at presentation, and in the next slide there, we will see that what stages do we most commonly get in lung cancer when we get the patients of this cancer, okay? Performance score, which in other words is the quality of life, and weight loss. So these three are important prognostic factors. In small cell lung cancer, again, these three factors: stage, performance score, weight loss, and in addition to them, lactate dehydrogenase levels, alkaline phosphatase levels, male sex, and hyponatremia. Right. So patients who are current smokers at the time of diagnosis have worse survival than patients who have never smoked. There could be some patients who quit smoking 10 or 15 years ago, but they have smoked for a long time. They are also high-risk patients. All right. TNM staging is the best prognostic factor. So stage is the first thing for non-small cell lung cancer and also small cell lung cancer. Small cell lung cancer, as I already mentioned, is diagnosed at a late stage. Right, so lung cancer is often insidious, producing no symptoms until the disease is well advanced. In approximately 7 to 10% of cases, lung cancer is diagnosed in asymptomatic patients on chest radiograph. For other reasons, you know, the patient comes to the hospital and you take a chest X-ray and you find something, a shadow or something, and then you do further investigations and you find out that it is lung cancer. Now, at initial diagnosis, what is the situation? The problem is, see, in the previous slide, I showed you that if it is localized disease, the survival rate at 5%, I've given you the percentages. Now, let us see at initial diagnosis, only 20% of the cases have got localized disease when the patients of all the lung cancer patients. When we diagnose them, only 20% have localized disease, and it is this 20% that have a survival rate of 59%, okay? 25% of the patients at the time of diagnosis have regional metastasis. They have got locally advanced cancer. It has either spread to the lymph nodes or it has spread to the adjacent tissues in the lungs, okay? So these are 25% of the cases, and survival rate over here is 32%. And 55% of the cases that come to us, they have got metastatic disease. Compare that to breast cancer, which was only about 10%. Here, 55% of the cases have metastatic disease, and they have got a very low survival. Okay, so that's the problem with lung cancer. We diagnose lung cancer at a late stage. Signs and symptoms of lung cancers may be due to primary tumor, locoregional spread, metastatic disease. You know, it can spread to the pleura, it can spread to the bronchi, depending upon the stage. It could spread to the diaphragm, to the heart. Okay, so it depends on the stage of the cancer. Cough is reported to be the most common presenting complaints. We have other complaints as well, like dyspnea. If there is pleural effusion or collapse of the lung, the patient can get chest pain, or hemoptysis means blood with sputum. All right. These are the signs and symptoms. I'll not go into the details. You can read them yourselves. And this slide is for reference only. Now, workup is important. The most, the first investigation that we commonly do is a chest X-ray. Okay. So we take the history, long history of smoking. We count them in pack years. I'll explain to you what a pack year is. And we also look at the signs and symptoms of the patients. So chest radiograph is the first thing we do. Then if the chest radiograph is abnormal, then we look at the location, if it is a central location or whether it's a peripheral location, okay? If it is a central location, which is close to the main bronchi, then we can do a sputum cytology. We can look for cancer cells in the sputum. You can do a bronchothoracic biopsy. You put a bronchoscope in the airways, in the trachea, in the main bronchi. And if you can reach the cancer tissue, you can take a biopsy. Transthoracic biopsy means you go through the chest wall, not through a bronchoscope, okay? If it is peripheral, you can do a biopsy, CT-guided transthoracic, which means you give a small incision in the skin and you go from outside, not through the airways. You can do a thoracoscopy, okay? You can put in a camera over there, or you can take a biopsy through a needle. Or you can do a thoracotomy, you cut the ribs and have an approach and take some material for biopsy or for examination. All right, and finally, you can reach a diagnosis of lung cancer. Now, staging, because of the importance of stage in therapeutic decision-making process, all patients with non-small cell lung cancer must be adequately staged, right? So the most important thing in deciding the treatment plan is the stage of lung cancer. A complete staging workup of non-small cell lung cancer should be carried out to evaluate the extent of the disease. And I'll go into some details of the staging. It is a bit complicated, but I'll leave it for your reference, but we'll discuss a little bit. So the investigations that you can do is CT scan of the chest, upper abdomen, complete blood count with differential serum chemistries, creatinine, electrolytes, calcium. You have to look at renal function as well, alkaline phosphatase to look at the metastasis in the bones or the liver, aspartate aminotransferase. You can do pulmonary function tests, lung volumes and lung capacities, and you can do a mediastinoscopy, okay? You can look into the mediastinum with certain techniques, okay? You can use cameras or something. Lung cancers have a propensity to cause paraneoplastic syndromes, which means they can produce certain hormones. Appropriate studies in such patients may include assays of serum electrolytes and BUN and creatinine, calcium, magnesium, okay, that I've already mentioned in the previous slide. Now, in squamous cell carcinoma of non-small cell lung cancer, there could be hypercalcemia because these, paraneoplastic syndromes, they can secrete a substance which is like parathyroid hormone. And you know that parathyroid hormone increases blood calcium levels. It extracts calcium from the bones. It will cause weakening of the bones in the long term. That is why, we use bisphosphonates in cancer chemotherapy. Many other cancers, they secrete this substance, which is like parathyroid hormone. Okay, so that will increase the calcium levels. Then syndrome of inappropriate ADH secretion, antidiuretic hormone secretion, that is going to lead to hyponatremia because that is going to increase the fluid volume, both the extracellular fluid volume, so the osmolality will be less than 280 milliosmoles, okay? And you have to make a correction, maybe in the handout I have written 28 milliosmoles. That was a typo. It is actually 280 milliosmoles. So the osmolality in hyponatremia will be less than 280 milliosmoles. We can have liver metastasis, then ALT, AST, gamma glutamyl transferase, PT and international prothrombin time, international normalized ratio, alkaline phosphatase, lots of tests. For respiratory failure, you can do ABGs, look for acidemia, CO2 levels, oxygen levels, okay? Many other investigations, I've already mentioned all of them, chest radiography and radiography, CT scan, MRI, bone scintigraphy, which is also known as bone scan, positron emission tomography, very expensive test, but it is a good test. It shows the metabolism of the cells, and cancer cells are highly metabolic cells. So we use tracer substance, radio-labeled substance known as FDG, fluorodeoxyglucose, okay? Then we can do sputum cytology, bronchoscopy, biopsy, so many investigations. Needle thoracocentesis. Thoracocentesis means taking fluid out of the lungs if possible. Thoracoscopy, molecular testing of the genes that I have mentioned, histological findings, screening, staging, okay? So lots of investigations. A chest radiograph is usually the first test ordered in patients in whom lung malignancy is suggested. It may not be useful in identifying the histologic type, which will be diagnosed on biopsy. So they may show primary nodules, mediastinal widening, atelectasis means collapse of the lung, hilar enlargement, and pleural effusions, okay? So, in this part of the lecture, I'm preparing grounds to discuss the treatment of lung cancer. We'll start with the treatment of lung cancers in the next lecture, okay? So maybe you might be worried that why I'm not discussing the treatment. We are going to discuss the treatment, but again, I'm going to keep the treatment at undergrad level. I'm not going into a lot of details. When you become postgraduates, I've, again, just like breast cancer, I've got a longer version of the lecture, which has got a lot of details of the treatment in every stage of the cancer. But here, because you're undergraduates, I'll not go into a lot of details. So here you see this chest X-ray, you see a big shadow over here. All right, so that will raise a suspicion of cancer. So you will take a biopsy or do other investigations, CT scan or positron emission tomography, whatever, depending. Again, you see a big shadow over here. This is a central tumor, okay? A large central lesion. See, it is close to these major bronchi. And what do you see? Any idea? What do you see over here? The lung fields are clear. In this, except for this shadow, the lung fields they appear clear. So these are known as costophrenic angles, okay? This is a big pleural effusion. And what they did was they took out this material through thoracocentesis. They took out a little bit of fluid, they examined it in the lab, and they found cancer cells, malignant cells. This is a positron emission tomography. They have seen a big cancer in the central regions of the chest. Right, biopsy, this transthoracic needle biopsy. I'll not go into details. I'll just mention to you that the false negative rates are high. Positive finding is reliable, but you get a lot of false negative findings, okay? So you have to do other tests as well, or you have to give bigger biopsy material. Diagnostic material can be obtained from other abnormal sites like lymph nodes or pleura or pericardial effusions. So needle thoracocentesis, again, I'll quickly go through this. You push in a needle, you can have wider needles, which is known as core needle biopsies. You can get more material line, okay? Thoracocentesis, if there is a pleural effusion, you take out the fluid from the pleural space, and this has got a sensitivity of 80%. You are still going to miss 20% of the cases, and specificity is greater than 90%, which means if there's the patient does not have cancer, in 90% of the cases, the result is going to be negative. But unfortunately, in 10% of cases, the patient does not have cancer, but the result shows that he has cancer. Okay, so that is a false positive result. Right, video assisted thoracoscopic surgery. Obviously, video, you have to put in a camera, make a small incision under local anesthesia, and you can visualize, you can take biopsies. Okay, so again, we don't need this thing in pharmacy. Molecular testing is important because treatment depends upon them. It includes testing for epidermal growth factor receptor and another gene, which is known as anaplastic lymphoma kinase gene mutation. Okay, such testing is indicated because very effective, less toxic targeted treatments are available. In breast cancers, we saw that targeted treatments are not very effective, but here in lung cancers, they are effective, especially in these two mutations. All lung cancer patients with adenocarcinomas should be tested for genetic abnormalities. And testing for RAS mutations, it is an oncogene, very important gene. If RAS mutation is present, then the cancer has got a poor prognosis. It is an aggressive cancer. Now, a word about the grades of non-small cell lung cancer. Grading is a way of dividing cancer cells into well-differentiated and poorly differentiated. Poorly differentiated cancers are aggressive cancers. They are bad cancers. So grade 1, they look very much like normal cells. They are slow growing and they are less likely to spread. Grade 2, you look at them, they are more likely to spread. You can still recognize they are like normal cells, but they are more likely to spread. And grade 3 and 4 are poorly differentiated. You look at those cells, you cannot recognize them. You cannot see or you cannot know whether they are lung tissues or lung cells or some other cells. Okay, so that is what we mean by poorly differentiated. Okay. Now we go on to staging, and we will stop after staging, although there is still some time, but we'll stop after staging. Okay, and staging has got quite a few slides. I'll go quickly through them. The most important prognostic indicator in lung cancer is the stage of the cancer, extent of disease, how many lymph nodes are involved, are the pleura involved or not, is trachea, the hilar regions, are they involved or not, is the heart involved, is the diaphragm involved, what is the size of the primary tumor, all these things are including in staging. The American Joint Committee for Cancer Staging and End Result Reporting has developed the TNM staging system. It takes into account the size of the tumor, 3 centimeters, 4 centimeters, 5 centimeters, 7 centimeters. How big is the tumor? Extent of lymph nodes involvement, whether any lymph node is involved or not. 1 lymph node, 2 lymph nodes, 3 lymph nodes. How many are involved? Okay. And distant metastasis, how many distant organs are involved in the cancer. Okay. So again, this is a very detailed explanation of the tumor sizes, TX, T0, carcinoma in situ, T1A, T1B, T1C, and this is for your reference only. Then we go to T2, T2A, T2B, T3, T4, I've given you all those details, but you don't have to memorize them. You have to keep them for your reference only when you go to your clinics. These slides are going to help you a lot in the staging of the cancers. Then this involvement of the nodes, lymph nodes, 1 node is involved, 2 are involved, or 3 are involved, or we don't know, it cannot be assessed, So it goes on like this. Metastasis, again, many different levels of metastasis, right? Again, we have combined all these in one slide. So this is the staging. It is so complicated. There are so many things, so many different combinations, okay? This is one combination, another combination, another combination, another combination. They are all stage B. Similarly, so many combinations in stage 3A, 3B. But again, for your reference only. Right, so I'm not showing you the stages I've written for reference, but we will discuss later whether to include them. It is very important, So here I've shown you the sizes. It's just like if it is the size of a large grape, it is 3 centimeter in size and no lymph node is involved, no metastasis, then we call it stage 1A. All right, just a small tumor, less than 3 centimeters. But here, what you see is the tumor is larger than 3 centimeter, but smaller than 4 centimeter, or it is 4 centimeter. Okay. Again, you see it is known as T2. Here it is T1. It is stage 1 lung cancer. It is stage 1B because the tumor size is increased, but nodes are not involved. There is no metastasis, still no lymph node. So it is stage 1B, stage 1A, stage 1B. Okay, we are still at stage 1. The only difference is that the tumor size has increased. And one thing I've shown you over here, this is the covering of the lung, which is known as the pleura. We have got 2 types, it is in 2 layers. One is visceral and the other is parietal pleura. So, the cancer is touching the visceral pleura. It is including if no lymph node is involved and the size is small, we call it stage 1B. Now, this is stage 2A. Now we have gone to stage 2. See, still no lymph node. If you remember in the breast cancer, if a lymph node, in stage 2, lymph node is always involved. It is always N1. But that is why TNM staging is different in different cancers. So the size of the cancer is big, still no lymph node. Okay, size of the cancer has gone up to 5 centimeter, greater than 4 centimeter, but up to, you see, they have given comparison. It's a walnut. This is a small green lemon, okay? So this is the comparison for size. And you see, again, it is size and it could, if you look over here, it is sort of invading the major bronchus, okay? And it is also invading the visceral pleura. See, if you look over here, this one is also invading, but the difference is this is larger in size as compared to stage 1B. This is stage 2A, right? So bigger in size, maybe the pleura are involved and still no lymph nodes. Now we get stage 2B and you see that the lymph nodes are involved. One lymph node, N1, N1, and you can have different sizes up to 5 centimeter. So when the lymph node is involved, it becomes stage 2B, right? With any size. Now here you have to help me. Okay, we have gone to stage 2B. This is also stage 2B, and this is also stage 2B, and it is becoming a little more complicated. Still no lymph node involved, but the size has become bigger. And you see, look at this pleura. This is the covering of the lung. It has invaded the visceral pleura and it has invaded the parietal pleura and it has gone into the chest wall. And if you look, over here, that this is the heart. And it is on this side of the lung, it has even invaded the pericardium, the epicardium, okay, the outer layer or the covering of the heart. So, as the stage is increasing, the size of the tumor is increasing, and the invasiveness of the tumor is also increasing. But here 2B, no lymph node in them. Now we go to stage 3A. Now you see we have got involvement of lymph nodes. 2 lymph nodes are involved over here. Okay, and 2. And again, you see pleura might be involved, or the trachea or the major bronchus might be involved. Okay, this is the carina. Carina is the place where the trachea divides into left and the right main bronchi. Okay, so I'm just giving you an idea that how the stages of cancer increases, and I'm going into more details because staging is important in deciding the treatment of the cancer. Again, I will need your help. You see the cancer size is very big, T3 and 1 lymph node. It's a big size, up to 7 centimeter, the size of a small apple. Okay, from 5 to bigger than a small, what you call this, a lemon, but up to, it can go up to 7 centimeter. And see the lymph nodes, 1 lymph node is involved. The chest wall has been invaded. It has gone through both the layers of the pleura. And even the heart layer has been epicardium, the covering of the heart has been invaded. Even the diaphragm, if you see over here, the diaphragm has been invaded. Okay, so it has gone to stage 3 now. And you see stage 3A, no lymph node or one lymph node, but the tumor size is very big, 7 centimeters. So we go further in the space. I mean, it is almost the same stage, but there is a possibility that the lymph node is not involved. But you see the carina, the division, the place where the trachea divides, diaphragm, vena cava could be involved. Okay, and hilar region, the breastbone, the sternum could be involved. It has even invaded the heart muscle. So very big size cancer. And then we go to stage 3B, in which more lymph nodes are involved. 3 lymph nodes are involved. N3 means 3 lymph nodes. Okay, anywhere you see 3 lymph nodes over here, 3 lymph nodes over here, and different groups of lymph nodes, supraclavicular lymph nodes. And it is very big tumor, and it is 3 lymph nodes are involved. It is even touching the visceral pleura. And what you see over here, maybe the lung has collapsed. Okay, you have got pleural effusion over here. So if there is a pleural effusion, it goes to stage 3B. Okay, I think previously we didn't have any pleural effusion so far. Yes, there is a pleural effusion over here. Okay, and this is stage 3A again. There is a pleural effusion as well. I forgot to mention that. Right, now we go on to stage 3B. Again, a different, either more lymph nodes are involved, the tumor size is small, or the tumor size is big and 2 lymph nodes are involved. And again, aorta has been involved, vena cava has been involved, this diaphragm has been invaded, carina, bronchus, these pleural coverings, epicardium. You see, I'm just trying to give you an idea how extensive is the cancer and how it is related to the stage of the cancer. You don't need to memorize it right now, but you must understand that there are so many different stages, and the stage depends upon so many factors that I've shown you in these slides: diaphragm, vena cava, aorta, carina, main bronchus, pleura, heart, the pericardium or the epicardium. So many things count. And then you go on to stage C. Even you see in stage C, it has even gone to the rib. The rib is involved. Okay, and all the things that we previously saw are involved. And 3 lymph nodes again, at least, 3 lymph nodes are involved. Okay, so and finally we go to stage 4, in which either it is stage 4A, only one distant organ is involved, or stage 4B, 2 different organs. It can go to kidneys, to the brain, to the liver, wherever. Okay, bones, 2 organs are involved. So that was all about the staging, and that is all for today. And next week we will go to the treatment of lung cancer, and we will start with colorectal cancer as well next week. If there are any questions, you can ask me. Otherwise, I know you're very tired, but now the holidays are over and you have to get used to 3 hours lectures. That's what the schedule is. The lecture time is 3 hours. I know it is difficult, but still, even today, what time is it? It is, we have done lectures for 2.5 hours, not 3 hours. All right. So any questions? All right, no questions, right? So see you next time.